Good evening, ladies and gentlemen, and thank you for joining us today. My name is Dr. Vineeth Nair, and I'll be your moderator for today's event. Today's webinar is the second of what is an ongoing series of academic webinars hosted by the Center of Excellence in Hematology at Suburban Diagnostics. The theme for today's series of talks is the multidisciplinary approach to the management of anti-phospholipid syndrome. We have an amazing lineup of speakers covering all the lab diagnosis, the management of thrombosis, and APS in obstetrics. I would like to remind everyone today that the webinar is interactive, and we'd like to encourage you to participate by submitting as many questions as you want at any time you want during the presentation. To submit a question, simply type the question into the chat box to your right and click send. At the end of this presentation, we will be having a consolidated Q&A session. If you have any trouble or seeing or hearing the presentation, please use the chat box to let us know. With this webinar, we will be giving certificates of attendance. All those who complete the webinars and wish to be provided with a certificate must fill a form which we will provide to you at the end of the webinar. Our first speaker for today is Dr. Amar Dasgupta, preeminent hematopathologist and director of medical services at Suburban Diagnostics. Over the past 4 decades, he has had a storied career in hamatopathology at institutions like the Postgraduate Institute for Medical Education and Research, Chandigarh, Tata Memorial Hospital, Mumbai, the University of Washington, Seattle, Hammersmith Hospital, London, Hinduja Hospital, Mumbai, and SRL Diagnostics, Mumbai. A fellow of the International Union Against Cancer and of the Indian Society of Hematology and Blood Transfusion, he was responsible for setting up India's first hybridomal laboratory and India's first cytometry laboratory way back in 1995. Today, he will be talking to us on a topic that is oft having a lot of confusion, that is the diagnosis of APS with special focus on lupus anticoagulant. Without any further ado, let me hand over the reins of this first session to Dr. Dasgupta. Over to you, sir.
Thank you, Vineeth. It's indeed a pleasure to have Dr. Bhave and Dr. Wagh on the panel today. As Vineeth mentioned, this is something which we are going to do in the future as well in terms of holding these webinars and CMEs as a part of our activity to commemorate the launching of our COE in hematology at Suburban Diagnostics. And I thank both of them and all the past and future participants for making this possible. The topic that we are covering today is, as I was speaking with Dr. Bhave before we decided about the topic, is something where there is a lot of information, but at the same time there is a lot of confusion. However, there have been attempts at multiple levels, especially at the level of the International Society for Thrombosis and Hemostasis, wherein through various scientific subcommittees that they have been constituting and activating, several guidelines and guidance points have emerged as far as anti-phospholipid antibody syndrome or APS is concerned. And today, therefore, in spite of the some ambiguous or nebulous areas that we see in this area of medicine, there are several important information which have kind of cleared some of the doubts that people were having till recently. And to share all that, we have Dr. Bhave and Dr. Wagh, and as well as I'll also try to throw some light on the current understanding of diagnostic approach to anti-phospholipid antibody syndrome. So anti-phospholipid antibodies and anti-phospholipid syndrome, as we nowadays call, there are certain facts that we would like first to recap, and that is APLA, as we call antiphospholipid antibodies as in short, are a heterogeneous group of autoantibodies directed against a complex of phospholipids and phospholipid binding proteins, which are also called cofactors that exist in various tissues in the body. So it is important to realize that it is just not the phospholipid part of the cellular constituent that these antibodies bind to, but they also bind, and in fact, more importantly, bind to a complex which results from combination of phospholipids and these various cofactors, as I've just now referred to. And important among these cofactors are beta-2 glycoprotein 1 and cardiolipin. Prothrombin also is considered to be another cofactor, and these are the ones which also are the, as the first point mentions, the target molecules for the antiphospholipid antibodies to act on. APLA are associated with a serious autoimmune disorder, which is the subject of today's discussion, and it's also mentioned here as anti-phospholipid syndrome. Earlier it used to be called anti-phospholipid antibody syndrome. And of the important cofactors that are important in terms of their significance with respect to the pathogenesis as well as risk factors is lupus anticoagulant, which is important as far as as I mentioned, the clinical manifestations of these conditions. And also accurate assessment of lupus anticoagulant is essential for proper management of APS patients. Now, through several layers of attempts made by, as I mentioned, the various committees and bodies constituted by the ISTH, what has emerged and is accepted today as diagnostic criteria are listed here. And what for APS diagnosis, one needs one clinical criteria out of the two listed here, and one biological criteria out of the three listed here. And as mentioned here, it's very important to confirm the persistence of these biological markers, one or more of these, 12 weeks apart, to show that indeed these findings were not one-off kind of a finding, and that indeed these are reproducible and are present in the patient over a long period of time. And that is important because, as we know today, that transient appearance of these antibodies is not unusual, and therefore one can see the presence of a particular marker at a point in time in association with various diseases, and then they disappear. But in the case of APS, these markers will persist. In other words, you have to show persistence of these antibodies over a period of time, as mentioned here, at least 12 weeks apart. This slide shows you a very brief outline of how we approach the patients of APS as far as diagnosis is concerned. So in patients where there is clinical suspicion of APS and they meet the clinical criteria, one will order a lupus anticoagulant assay, anticardiolipin assay, as well as beta-2 glycoprotein 1 assay. And along with that, as I have mentioned in the footnote, one must also ask for some of the screening coagulation assays, because lupus anticoagulant being a specialized, or other tests as well, being specialized tests, the availability of these tests locally is always a challenging issue. And therefore, under many circumstances, the samples for these tests are transported, and deterioration of the sample and therefore the change in the results is highly likely under these circumstances. And therefore, one would like to do, in addition to these primary or mainstay tests, some screening tests of coagulation to be sure that the abnormalities that we see in the patient sample are not due to sample deterioration or acquired factor deficiency very often as a result of deterioration as well. and of course heparin and oral anticoagulant contamination, because very often, at least in the reference labs that I have worked in, we have seen patients' samples being sent across when actually the patient is on some sort of anticoagulation. And that is a sample which definitely is not suitable for undergoing these tests. And therefore, it is important to realize that one should include some of these tests to exclude these variables that can vitiate the results of these tests. And I'll be dealing in these particular aspects a little later. As just now mentioned, there are two types of two sets of assays. One, as mentioned here, is the liquid phase-based assays. Example is lupus anticoagulants, wherein the anticoagulant is actually directed against, as we know today, beta-2-glycoprotein 1, as I mentioned just now, and as well as prothrombin. And this is important because this also is linked to the one of the reasons why we get venous and arterial thrombosis in patients of lupus anticoagulants. The other sets of assays, these are the two other mainstay assays, as I already mentioned, are anti-cardiolipin antibodies and anti-glycoprotein 1 antibodies. And these are usually solid phase assays in the sense that they are usually EIA-based assays. And unlike lupus anticoagulant, which is very closely associated with, or the presence of which is closely associated with pathogenesis and disease per se, manifestations thereof per se, anti-cardiolipin antibodies and beta-2 glycoprotein antibodies are less commonly associated with pathogenesis and morbidity and mortality in these cases. What is important also to appreciate is that some of these autoantibodies are found in almost up to 5% of normal individuals and in approximately 30 to 40% of patients with systemic lupus erythematosus. So this is a point to keep in mind. Now coming to lupus anticoagulant, and my talk will mainly focus on this particular antibody, is actually, as you'll appreciate, a misnomer, because although it is labeled as anticoagulant, it actually causes both venous and arterial thrombosis in the patients. And the reason for that, of course, we'll look at. And why it is called anticoagulant is because it causes prolongation of phospholipid-based coagulation assays, for example, APTT, in the laboratory. And the reason for that is obvious, that phospholipid is a very important ingredient of both in vivo clotting or fibrin formation, as well as in vitro in the test tubes. And therefore, antibodies which are directed against phospholipids or phospholipid protein complexes would hamper clotting of blood in the various laboratory assays. For example, APTT is a very good example of interference of in the assay by lupus anticoagulants. And therefore, all the APTT-based assays will get impacted by lupus anticoagulant, and also, therefore, the assays that are used to detect lupus anticoagulant are APTT-based, and that we'll again look at later on. And lupus anticoagulant belongs to, of course, as we already know, anti-phospholipid antibodies group, and leads to anti-phospholipid syndrome. Now, I did refer to the mechanism of action, whereby the APLAs, as well as mainly lupus anticoagulant, causes arterial and venous thrombosis in patients What we know today is still, of course, not clear. The exact mechanism, therefore, is not known. But there are multiple possibilities, and some of these are like interference with coagulation pathways, the interference with the natural anticoagulant pathways like protein C, protein S, and tissue factor pathway inhibitor, as well as activation of cellular components or cells which secrete procoagulants, say, for example, platelets and monocytes. So by virtue of, I suppose, multifaceted action of lupus anticoagulants on the coagulation pathways, as well as some of the cells, that it leads to increased tendency to arterial and venous thrombosis. And by the way, this is one of the rare conditions in which you get both arterial and venous thrombosis, unlike most of the other causes of thrombophilia. Of course, homocystinemia or homocysteine elevation in blood, either inherited or acquired, is known to be associated with arterial as well as venous thrombosis. And therefore, the causative mechanism is not really well understood in these, in terms of the venous thrombosis that we see. And as I mentioned, LA is more strongly associated with thrombus formation as well as fetal loss compared to the other antibodies in the anti-phospholipid group. Lupus anticoagulant is present in 5% of healthy pregnancies as well as in 11 to 29% of women with preeclampsia. And therefore, the interpretation of LA assays in pregnant women needs to be viewed in line of this finding or this observation. And there can be difficulties in interpreting the data because of false positivity in patients who actually do not have LA, in particularly pregnant women who do not have LA, yet the test is positive. One must consider several factors, and these are usually situations which are pre-analytic, and they can influence the results of lupus anticoagulant testing. And these are any acute phase position or situation. And for example, what happens in the setting of acute thrombosis, wherein the interpretation of the data in terms of LA testing has to be done with caution, as false positives and false negative results can occur. LA testing may be useful in the new stroke patients in whom APS is clinically suspected in order to decide whether the patient would benefit from anticoagulation rather than antiplatelet therapy. And therefore, there could be a use of this test in these situations, even though it's an acute phase situation. LA testing should not be performed in patients receiving anticoagulant treatment, as false positive and false negatives can occur. However, if LA is clinically necessary, LA testing is clinically necessary in anticoagulated patients, the following points should be noted, and that is, in vitamin K antagonist treated patients, the interpretation of lupus anticoagulant results is challenging because of the prolonged basal clotting time. If feasible, perform LA testing 1 to 2 weeks after discontinuation of the VKA, with consideration of low molecular weight heparin bridging in patients who require continuous anticoagulation. Continuing with that, in case of treatment with low molecular weight heparin, samples should be taken at least 12 hours after the last dose of drug, and as near as possible to the next dose, with anti-10A activity level being checked alongside the LA test. Now, this is a little complex situation, and it may not be easy to get an anti-10A assay readily available. And therefore, how far this is practical, one will have to say, although the fact remains that low molecular weight heparins do not impact the LA testing to that extent as heparin would. If feasible, temporarily, one should interrupt in case of the therapy in case of DOACs, and at least for 48 hours before the last testing the patient after the last dose. Longer in case the patient has renal impairment, because it is known that patients who are on DOAC continue to have higher level of the drug if they have renal compromise, because the drugs are excreted through the kidneys, and therefore the action can get prolonged because of that fact. Incorporation of information of the patient's anticoagulation status in the request form is mandatory for the lab to know, so that the interpretation of the data can be done in light of this fact. Results of earlier testing during pregnancy should be interpreted with caution, as false positives and false negative results can occur. Repeat testing should be considered at an appropriate time post-delivery to obtain reliable LA results. I'm sure the other speakers will throw more light on these aspects. Lupus anticoagulant testing is by design done through 3 phases or 3 steps known as screening, mixing, and confirmation. In the screening test, there are 2 tests which are recommended, as I mentioned, APTT, and another similar test which is called dilute Russell Viper venom time, or DRVVT, and it is mentioned or recommended that DRVVT should be the primary test, and one should do APTT as well. So one should do these 2 tests, and if you have one of the 2 tests positive, that is a situation where the patient is fulfilling the diagnostic criterion for to be qualified as having APLA or APS. The next step is the step of mixing studies, where basically one tries to show that the prolongation of APTT and DVVRT DRVVT, are not due to inhibitors and are indeed due to the not due to factor deficiency, but are indeed due to inhibitors, in this case lupus anticoagulant. And finally, the logic of doing confirmation is that since the antibody in lupus anticoagulant is directed against phospholipids, if we repeat the assays with additional phospholipids, it is expected that the antibody effect of the drug, the LA will be reduced or neutralized, and as a result of which the prolonged clotting time that we are looking at, either RVVT or LA sensitive APTT, gets corrected. And this is what is the basis which is used to determine the confirming the diagnosis. So I think we'll skip some of these slides because of paucity of time. But in principle, what I have mentioned is covered in this. But what is important is, of course, to appreciate that the lab has to establish its own cutoff value for all the 3 types of assays that just now we have mentioned. And this is something which is usually not done by most of the labs. And expressing the results against borrowed cutoffs or cutoffs recommended by the manufacturers of the reagents is something which is not recommended. And therefore, one should try and establish that, although that's a big challenge which one will have to keep in mind. This is just an example of how a typical case of person having lupus anticoagulant would show the abnormalities in APTT, DRVVT screen, and DRVVT confirm. And as you can see here, finally the ratio, which is normalized ratio, is what we look at. And in this case, the normalized ratio in the patient was 1.9, against the cutoff of 1.2, and therefore this is a case of lupus anticoagulant positivity. And there are indications of that in the earlier sets of assays, wherein you can see that the 1:1 mixing in the APTT assay using sensitive reagent did not get the prolonged APT did not get corrected by adding normal pool plasma, and that itself would have given an idea of the presence of an inhibitor or an anticoagulant, and then that we confirm by doing the RVVT, both screening as well as confirm. I think what is important here, that which I have last listed here at the end, is the repeat testing is required after an initial positive result on a second occasion after at least 12 weeks to confirm the persistent positivity, which is a point we should emphasize and practice because of the issue of transient LAs that we come across. Just one slide on the lupus testing in patients on anticoagulation therapy. Anticoagulants, mainly unfractionated heparin and DOACs, influence LA tests by yielding false positive or false negative results, usually false positive results. Hence, LA testing in patients on these anticoagulants is not recommended. LA test is less affected by low molecular weight heparins, as I mentioned earlier. Incorporation of heparin utilizers in LA testing reagents have limited role, while the use of DOAC adsorbents, which are being tried nowadays in the assay, appears promising. Vitamin K antagonists significantly affect the results of LA tests, and therefore they should not be given to patients, or the patient should not be on these drugs when the LA is being tested. And overall, LA testing in patients on anticoagulation is challenging, and the results can be difficult to interpret. Testing can be done after a variable gap following discontinuation of the drug, and this is something which we have to keep in mind. And I think we'll skip this also. And just one slide to show that there was a survey done in 2011 to see how many labs which perform LA testing are following the ISTH SSC guidelines in terms of the requirements to ensure that the results of the testing are reliable. And one of the facts which emerged there that from this study was that the cutoff that one needs to set up within the labs before one embarks on doing the three-step screening, utilization or mixing and confirmatory assays was not followed by 90% of the labs. And therefore, the question of the data that are being generated from these labs and their reliability would be something which there would be a question mark against that. And at the same time, one can see that the choice of tests, which I just now mentioned, should be RVVT and APTT, was also not followed in 50% of these labs in the survey. And these are data coming out of of Europe. And similar experience has been there from the other subcontinents. And therefore, this is something which I'd like to emphasize mainly to my colleagues from the laboratory who may be participating in this webinar to keep this fact in mind. So the take-home message is that APLAs or anti-phospholipid antibodies are a heterogeneous group of autoantibodies. They are clinically important, and amongst them, the most important ones are the lupus anticoagulant, anti-beta-2-glycoprotein 1, and anti-cardiolipin. There are recent reports to show that all the antibodies, autoantibodies, which give rise to APS, need not necessarily be targeting these three molecules only, but they would be targeting some other molecules which ultimately give rise to same outcome. And therefore, one would one can explain why in many cases of in many cases of APS, anti-phospholipid antibody syndrome, one does not get positivity for LA, anti-beta-2 glycoprotein 1 or ACL. And that explains why this must be happening. Persistence of APLA needs to be demonstrated by repeat testing 12 weeks apart to rule out transient APLA. Although a multi-system disease, venous and arterial thrombosis and pregnancy loss are two major clinical manifestations of APS, about which we will be hearing shortly. A host of pre-analytic variables affect the results of APLA testing, especially lupus, especially in the case of lupus anticoagulant. Lupus testing should not be performed in patients on anticoagulation therapy. Proper selection of patients and right time of testing are vital under these circumstances. Correct choice of reagents and method is mandatory for reliable results of LA test. A three-step approach consisting of screening, mixing, and confirmatory tests using the right kind of reagents, having the right kind of activators should be used. Laboratories should establish in-house cutoffs for all the three steps mentioned above. And this is a challenging proposition because to obtain a 99 percentile cutoff of a normal population, you need to do at least 200 normal persons screening. And that is not an easy thing for smaller labs. And therefore, this is something which is neglected. And as I said, the cutoffs used by the labs are usually borrowed cutoffs, which I think needs to be discouraged. And although there are now recommendations that one can use the data from 40 normal people, normal adults, and use that as a substitute for 99th percentile. But the recommendation, the latest one in 2020, which came out of the ISTH, says that it is desirable and recommended that the lab should have their own cutoff based out of 200 normals. And that is therefore the situation and an unresolved challenge, I suppose, for most of the labs in our country. And this is what is mentioned here. So I think this is my last slide, and thank you all very much for your attention.
Thank you, sir, for that informative presentation. Our second speaker for today is Dr. Abhay Bhave, a highly renowned consultant pathologist from hematologist from Mumbai. Armed with an ever-winning smile and fellowships in hematology from CMC Vellore and the Royal College of Pathologists of Australasia, Dr. Bhave is a member of the ICMR task force for the National Guidelines for MDS, for the National Guidelines for DBT, for newer anticoagulants, and the guidelines for pulmonary embolism. He's a Dr. B.R. Ramasubramaniam Oration Award winner from the IMA and Ekta Manch Awardee for community service. An avid academician as well as clinician, Dr. Bhave has numerous national and international publications to his name and is on the editorial board of a number of academic journals. Take it away, Dr. Bhave.
Thank you very much, Vineeth. I hope my slide is being seen.
So your slide is visible. If you can just put it on the screen, so the slide show more. Yes.
Okay.
Yes, perfect.
Okay, so thank you very much, Dr. Dasgupta, for this opportunity to be on this panel with you and Dr. Wagh, and on a topic which is extremely important from the point of view of for the clinician. And I thank the entire staff who's also working at Suburban Diagnostics to make all of us come together on this platform for this discussion today. So the job description for me is to speak on challenges in the management of vascular thrombosis and anti-phospholipid antibody syndrome. What you're seeing in this slide over here is on the top, you're seeing a pulmonary embolism, you're seeing an acute myocardial infarction in the ECG, you're seeing something like a livedo reticularis or acymosa on the skin, you're seeing digital gangrene in this patient, and you're seeing schistocytes on the peripheral smear. All these are manifestations of APLA syndrome or anything that is microangiopathy. The issue is, and that's where the challenge is, how to diagnose this condition. Now I've brought about 8 points, and then I'm going to put the entire perspective in a nutshell. These are the issues or challenges that we face as clinicians in APLA, and I'm hoping that I can go through these with you quickly. So if you look at first the pathophysiology of thrombosis in the APLA syndrome, we all know that it's an acquired autoimmune immune disorder. It is also called as the Hughes syndrome. It was described in 1983. And this is, you're not born with this, it's not inherited. This is something which you acquire. Now, essentially over here, what we see is that there are anti-phospholipid antibodies which are produced, and the producer is the B cell. Once these antibodies are produced by the B cell, these antibodies float around in the blood, and then they attach to the beta-2 glycoprotein, which is present on the endothelial surface or expressed on the endothelial surface. So they form an anti-beta-2 glycoprotein 1 antibody. They adhere to the D1 domain. Once this adherence takes place of the antibody to the beta-2 glycoprotein, then a series of events takes place. There is activation of inflammation where the cells come into play, neutrophils, monocytes, they interact and they start producing inflammatory cytokines into a process which is called as netosis. And it's called as a netosis because it is neutrophil extracellular traps. And these inflammatory cytokines actually work on the platelet template which is forming here. And this platelet template acts as the primary site on which the coagulation factor starts getting activated at the site of the endothelium. And a clot starts getting formed where there is platelets, fibrin, white cells, and all the inflammatory cytokines that are there together over here. So this promotes the process of coagulation. Usually in an injury, it is then chipped down by the fibrinolytic process to a customized clot, which only covers the area which is injured or damaged. But in APLA syndrome, you don't need an injury or damage. It happens intrinsically in the blood without any damage, just because of the inflammatory cytokine being released. As a result of which, the clot can propagate itself forward, and there is no end to it, and it acts like most probably a dissemination of the coagulation towards further downstream regions. This can happen either in the bigger vessels, or predominantly it happens in the smaller vessels of the organs. And the same kind of a behavior of pathophysiology occurs in the placenta, in the trophoblasts or the decidual cells, where as part of this pro-inflammatory process, there is thrombosis, which leads to placental infarcts. And that's why we get the recurrent pregnancy losses or issues which take place during pregnancy when the anti-phospholipid is strong. And we're going to hear more about this from Dr. Girija Wagh. So in this situation, we've got anti-phospholipid antibody, which results in inflammation. It causes vasculopathy, and it causes thrombosis. And at the end of the day, all this actually leads to, are you able to see my slide?
No, Doc, we're seeing the webinar platform. You'll have to go back to your PowerPoint.
Yeah, something happened along the way. Sorry about that. Am I on now?
Yes, you are. Yes,
Yeah.
we can see.
So as part of this unholy nexus, we start getting thrombosis, and the same thrombosis extends on to pregnancy. So APLA causes inflammation, vasculopathy, and thrombosis. And that's the pathogenesis or pathophysiology of thrombosis in APLA syndrome. The next issue is, how do I diagnose APLA? So we've been told by Dr. Dasgupta that lupus anticoagulant, anticardial lipid antibody, and beta-2 glycoprotein antibody are the three main antibodies that we ask the laboratory to do for us to be able to make a diagnosis. But we also look in clinical picture the ANA, dsDNA, and complements, that is C3, C4, because importantly, we know that those with autoimmune disorders such as SLE have a higher incidence of this lupus anticoagulant. So we don't want to miss out on SLE. And I'll show you that SLE has higher incidence of certain prothrombotic events. We also do the CBC, ESR, and the CRP just to see what is the level of the platelets, because thrombocytopenia is a common feature of APLA. We look at ESR and CRP to see infection as a reason for worsening in a patient who otherwise was fine, even if he or she had SLE. The incidence of APS is approximately 5 new cases per 100,000 people per year. So the incidence is not very high. The prevalence is around 40 to 50 cases per 100,000. That means the common man out in the population, there are some people walking about with this antibody without there ever being a manifestation of this disease process. However, when they have a clinical event like a thrombosis or obstetric related event, then suddenly the prevalence of the anti-phospholipid antibody seems to be different. For example, it is 13.5% in stroke, 11% in myocardial infarction, 9.5% in deep vein thrombosis, 6% in pregnancy-related issues, including pregnancy-related morbidity, and 26.4% in women with early recurrent pregnancy loss. So suddenly when an event takes place, the precipitation of the event makes these antibodies become stronger, or the other way around, that the antibodies have become stronger, so they make events. It's hard to know which came first. But this is the way the anti-phospholipid antibody behaves in the general population. So while the absolute annual risk of a first thrombotic event in a patient who's got a positive APL is less than 1% per year, this suddenly increases to 5 times when they have an additional risk factor, such as obesity, smoking, tobacco ingestion, or other autoimmune diseases, especially SLE, or other transient risk factors that cause thrombosis. So it is an add-on to an coexisting or a comorbidity which may make these antibodies behave in a rogue manner. So which patient does need an APLA workup? You can't just do an APLA study for everybody because it adds to the cost and healthcare is becoming more and more expensive. But you'll notice that amongst all these 7 areas that I've highlighted, there is thrombocytopenia as one of the manifestations of APLA syndrome. You'll be surprised at the number of people we pick up who have got no thrombosis, but have got thrombocytopenia as the first manifestation of APLA syndrome. But otherwise, you'll see that it is the microangiopathy or the thrombosis, which is a common link between all, such as venous thrombosis, arterial thrombosis, obstetric, it's a recurrent pregnancy loss because of placental infarction and thrombosis. Neurologically, it is stroke. Cardiovascular, it is stroke. It is livedo reticularis or racemosa, or skin ulceration and necrosis because of skin thrombosis. There is renal microangiopathy causing proteinuria, and there is avascular necrosis of the bones in orthopedics because of vascular thrombosis. So the common pathophysiology of these antibodies is to create a clot which in different organs manifests differently. And one of the other manifestations is thrombocytopenia. So patients who have got unexplained thrombosis at unexplained sites, they are the ones who end up having to test for the APLA syndrome. So can I now risk stratify patients with thrombosis in APLA? And this is very important, as you'll see later on, for the process of treatment. So if I've got just one antibody which is positive, then my odds ratio of getting a clinically relevant event is between 1 to 5. As it goes higher, like dual positivity or triple positivity, my odds ratio of getting a clot significantly increases. That means more the number of antibodies, the higher is the likelihood of the patient getting a clinically relevant event. Note that a lupus anticoagulant alone behaves like a dual positivity and alone is enough to cause clots. And that's why in recurrent pregnancy losses, as Dr. Wagh will tell you later on, I'm sure, that LAC is very important in those patients who've got less than 10 weeks loss in fetuses. But this is the way we can risk stratify and know whether our patients are at a higher risk of getting a clinically relevant event. So if you've got the cohort of patients, you've got the testing done, is it possible to prevent the clotting in this patient rather than let him or her have the clot and then expect to treat it as a therapeutic event? So let's see if prophylaxis, we can do something like prevention is better than cure. So that would be called as primary thromboprophylaxis. So if you've got a patient who's APLA positive, but the patient is asymptomatic, not fulfilling any thrombotic event or obstetric event, but has a high risk APL, that means 2 or more tests which are positive. Irrespective whether this patient has any other risk factors, this patient will do well with low dose aspirin, anywhere between 75 to 100 milligrams. And what have we realized from data? That the risk of the first thrombosis in such patient is reduced by 50% if you were to take this low dose aspirin versus not taking aspirin. And I think it's very important if we can make a difference in the community to 50% of patients who got APLA, then I think we have made a difference to the society. What if this patient who is APLA positive is also an SLE, but she has no evidence of thrombosis or pregnancy complications? Then here again, if she is a high-risk APLA, the fact that she is SLE means she will be given low-dose aspirin. However, if she's SLE, but she's got a low-risk APLA, she's got probably just one antibody positive, then you may want to give a low-dose aspirin based on what her other comorbid conditions are. So it's not necessary she has to get it, but if she's obese, she tends to be immobile, her job is such, she flies frequently, more than 6 hours, then in that case, these are better off having the LDA. And again, data has shown that if they take LDA, the relative risk reduction of thrombosis is 50%, which is a good event in society. What if they are antiphospholipid anti-positive and it's a woman who's had an adverse obstetric event in the past? She may not be having SLE at present, but she's had one obstetric event in the past. Then she also needs to have a low-dose aspirin, provided she doesn't have a risk of bleeding. For example, her thrombocytopenia, if it's there, is not severe. This was learned from meta-analysis of 5 observational studies, where the protective effect of the low-dose aspirin was supported by 3 retrospective studies. Unfortunately, the number of SLE patients were very less, but nonetheless, there was a benefit of taking low-dose aspirin. And those who've had a history of obstetric APS-related obstetric event, then such women, based on their criteria of bleeding or clotting, would benefit out of aspirin. So it looks like aspirin would be needed for all those who have a triple positive, dual positivity, or have other transient cofactors or comorbidities which might make them clot. They'll benefit out of aspirin. Suppose we missed the bus, or the patient didn't come to us in time to be able to give her or him prophylaxis. Then they have developed a clot. How do I treat? So that comes to therapy. So these are called secondary prophylaxis or secondary thromboprophylaxis or therapeutic doses of APS. So if the patient is a definite case of anti-phospholipid antibody, and this is the first venous thrombosis, then it is recommended to take a vitamin K antagonist, which is most commonly warfarin. And the target we would keep is somewhere of INR between 2 and 3. Usually we do not start warfarin on its own. We have to give low molecular weight heparin or unfractionated heparin based on the clinical picture, initially as a bridge till the warfarin is reaches an INR of 2 and 3. This is because when we start warfarin, don't forget protein C and protein S are also dependent on vitamin K. So if we give warfarin without its co-partner heparin, then protein C, protein S will go low, and those are natural anticoagulants. So your risk of clotting is higher. So you might actually make the patient clot more because of the deficiency of protein C, protein S. Hence, in order to prevent that protein C, protein S from creating a problem, we give heparin to keep the blood thin in the time when the blood has become thin completely. It takes about 3 days for the vitamin K dependent factors to become adequately decreased so as the patient remains at a thinned out level. Hence, we need about 3 to 5 days of bridging with heparin till warfarin has its relevant effect of making the blood thin enough to achieve an INR of 2 to 3. Is it necessary that we have to go to a higher dose because it's lupus anticoagulant? Data has shown from random control that it is not necessary to go to a higher level in the first episode of venous thrombosis. Also, if you go to a high level between 3 and 4, there might be a higher risk of bleeding, which might put you back and prevent you from anticoagulating that patient, which will add to the thrombotic potential. What about secondary thromboprophylaxis in APS patients who are desirous of taking direct oral anticoagulants? Well, there is limited evidence of effectiveness. So it is only used for those patients who are not able to achieve a target INR despite good adherence to warfarin, or those who have got contraindications to vitamin K anticoagulants, vitamin K antagonists, such as allergy to warfarin, rare, or intolerance to taking this drug, unable to do INRs on time. In a post hoc analysis of patients with antiphospholipid syndrome, which had 3 RCTs in it, where dabigatran and rivaroxaban was studied, we came across a lot of data. It showed clearly that there were no differences in outcomes between treatment with DOACs and VKA for venous thromboembolism patients with APS. But these samples were small. There was underrepresentation of high-risk patients, so we don't know whether they'll work in high-risk patients. And the follow-up was short, and therefore a clear-cut benefit that we see with warfarin was not assessed adequately with the DOACs. And a recent randomized controlled trial of rivaroxaban versus warfarin in patients with antiphospholipid antibody who had a triple positivity had to be prematurely terminated due to excess thromboembolic events, especially arterial events, in the rivaroxaban arm. Therefore, rivaroxaban should not be used in patients who have triple APL positivity. What if this patient had an unprovoked first venous thromboembolism? So we know that in the venous thromboembolism, we have to use warfarin. Avoid DOACs unless they are single. It's a single positivity. Or they are not tolerant of warfarin. What if they are unprovoked? If they are unprovoked, then anticoagulation should be going on for long term, because the provoking factor here could be the could be the antiphospholipid antibody, but the clinical event was without a reason and therefore it's unprovoked. If this unprovoked event has a triple positive antiphospholipid, then that will continue to create a thrombosis in this patient, unless, as Dr. Dasgupta mentioned earlier, the antiphospholipid is transient in nature. It disappears. In which case, if it has disappeared, then it is less likely to be the reason for the thrombosis. It may have been an add-on to another reason. So we have to view antiphospholipid depending upon the clinical situation. Clearly, it is mentioned that the patients who are unprovoked would be treated like any other patient, irrespective whether there is antiphospholipid antibody or not. The only difference is, that means long-term anticoagulation. The only difference is, in the other patients who don't have antiphospholipid, we would love to use the DOACs because the DOACs don't need to be monitored. There is no issues about food, eating food, and the risk of bleeding is much lesser. We can't do that in APS who got unprovoked DVT, because long-term anticoagulation cannot be done with DOACs unless it's a single antibody positivity. If they have a triple antibody positivity or a lupus anticoagulant strongly positive, they need in any patient who has got thrombosis. What if the patient has a provoked first venous thromboembolism? That means it was a reason which was transient. We knew why, such as surgery, such as maybe it was immobilization or something like a long flight. In that case, these patients would need a fixed amount of duration. That means 3 to 6 months as per standard for those who did not have antiphospholipid. But if after that 3 to 6 months is over and the antiphospholipid remains there, it becomes a provoking agent, and hence you continue long-term anticoagulants. So those who are high-risk antiphospholipid, even if they had a provoking event, they will continue to take the anticoagulation for a longer period of time based on their risk profile. So if they're high risk or their persistence of antiphospholipid antibody syndrome, they will continue with longer anticoagulation till the time we demonstrate that the antiphospholipid antibody is gone. What about these patients who have had a clot, who have taken either warfarin or DOAC as per what we have studied, but despite taking that, they have recurrence of events. They get recurrent events. In such a situation, when they're getting recurrent events, look at the target. Have they been keeping themselves at a therapeutic target of 2 to 3? If yes, then it means we have to go to a higher dose of INR, keep it between 3 and 4, or you can add an aspirin, low dose aspirin to the INR of 2 to 3, or you can change to low molecular weight heparin, which works equally well, but it is injectable and it's not so easy to do. Hence, you might just want to add aspirin. However, if the patient was not taking warfarin properly, then it's a compliance issue. Then educating them and telling that it's in their interest to take warfarin, which is, pardon my saying so, but Sasta, Mazboot, Tikau, Sundar way of anticoagulating patients. If they can be trained to take their warfarin on time, avoid certain food items, then it is the best way to manage patients. If their time to therapeutic range is between 2 and 3 consistently, they will do very well. What about those patients who got an arterial event as part of antiphospholipid syndrome? Again, it's the warfarin therapy is recommended over using just aspirin alone. And if it is arterial event, especially with triple therapy, please do not use rivaroxaban for such patients, as not only the TRAPS trial of rivaroxaban showed that it is not worth it, the recurrence is higher, but the apixaban also in the Astro APS showed that they had to modify the study so that they did not include the arterial thrombi, and then they were non-inferior. Hence, DOACs is not currently recommended in patients who have got a definite APS, triple positive especially, and who got an arterial event. What if those who are arterial event keep getting recurrent arterial events? Then it's the same thing like the venous thrombosis. That means you can keep the INR higher at 3 to 4, make them become more compliant to warfarin, or add low dose aspirin to the INR of 2 to 3, or switch over to low molecular weight heparin. This is quickly to show you the clinical trials of patients on the DOACs. What a fantastic drug. We would have loved to use it, but I would want you to concentrate here. The incidence of thrombosis and the major bleeding, unfortunately, was higher with these DOACs, and hence we will not be using these in clinical practice, and we would consider warfarin as a drug of choice. So avoid DOACs if triple positivity and history of arterial thrombosis. So why did these DOACs not work? I tried to look up literature and I found several reasons. That DOACs is a single target. It inhibits either 10A or 2A, unlike warfarin, which inhibits multiple sites both in the intrinsic and extrinsic pathway. So its ability to prevent the generation of thrombin is far superior to the DOACs. Also, sometimes with DOACs, because it's easy to take, compliance becomes an issue reversely, and people forget to take the medicines. When you have to do tests for INR in warfarin, they remember that they have to take warfarin on time. And maybe there's a higher requirement of the DOACs for patients who got arterial thrombi as compared to venous thrombi, so that they don't get arterial. But then when you go to a higher dose of DOAC, the worry is always about a risk of bleeding in these patients. We come to one very important aspect which clinicians have to know, especially those who are internists or those who are intensivists or physicians in practice. There's something called as catastrophic APS. It was introduced in 1992 for a subset of patients who have APS who got a life-threatening microangiopathy, where small vessels get involved rapidly, giving rise to a multi-organ failure, and its morbidity and mortality is extremely high. Fortunately, it is very less. The incidence is probably 1% of cases of antiphospholipid. But the reason a patient might get it is because, say, an infection took place, or the patient got admitted to the hospital for some reason, and they discontinued anticoagulation. So a triple positive APLA who has had a thrombus, you stop it for any reason, and if you don't give some kind of a bridging therapy, they're likely to go into CAPS, either preoperatively or postoperatively, especially if there's infection, or there are major surgical procedures which need long anesthesia time. They need to be quickly diagnosed, especially with the digital gangrene which I showed you, and they should be put onto unfractionated heparin immediately, or low molecular weight heparin, as the case might be. We add steroids or plasma exchange and or immunoglobulin to these patients. Otherwise, you're going to lose these patients rapidly. Concurrently, treat the reasons for them going to this situation, that is infections, gangrene, or treat the underlying malignancy, and that will help you to come out of the syndrome. For refractory CAPS, we can use a drug such as rituximab, which goes against B cells, which I told you was producing the antibody, or eculizumab, which I'm going to talk to you about now. In my reading, did I come across unmet needs in the treatment of thrombosis in APLA? And that's a challenge. We know that antiplatelets and anticoagulant agents are the ones which give us the mainstay of antiphospholipid treatment. But we don't know the intensity of anticoagulation. We don't know where 2 to 3 is fine or 3 to 4 is what we should do. We typically let them have a thrombus again in order to go higher up on the intensity. What is the duration of anticoagulant? Will we stop for a provoke or continue with the provoke DVT? Do we have to look at it differently in the treatment of stroke or refractory cases? Do we have to give a dual antiplatelet along with the warfarin? Can we use a DOAC along with dual antiplatelets? We have got a condition called as seronegative APS because we as clinicians are confident that this behaves like an antiphospholipid, but the lab is not able to give us a positive report. These are called seronegative APS. And these people will be treated just like the APS, aggressively and preferably with warfarin. And the most relevant are the antiphospholipid profile. We don't know how strong is strong. What is the MPL units or GPL units that we need to say that this patient is strongly positive? If its cutoff is 40 and my patient is 45, if it's an IgM, what does it mean? So there are too many ambiguous issues in the treatment, in the diagnosis of APLA, which I'm sure in the question answer session, Dr. Amar Dasgupta will take it up. And we don't know why some vessels are more involved, like in pregnancy, why the trophoblast and decidual more involved. Why is the stroke in the brain more common and not in the other arteries? Why is it that the heart arteries, coronary arteries are involved? What is there in the endothelium which makes these APLAs? Is there more secretion of phospholipids in certain endothelia? We don't know, and we don't know about that study. But there is something which is called as complementopathy. Now, Hopkins thrombosis score is the only one which looks as complement. LAC is very important in the thrombotic manifestations of APLA in any patient with VTE artery or pregnancy. C3 is also important. Low C3 is important. Low C4 need not be so important because it can be part of a genetic deletion which might occur in normal people also. But a low C3 is important because it is known to cause a complement-mediated activation of the inflammation. But what is important recently is the platelet-bound C4D. This C4D can actually bind to the platelets when it is activated. And by binding to the platelets, it activates the platelets. And we all know platelets are responsible for thrombosis. And we also know that it happens in COVID. So this detection of this bound C4D on the platelet might be a very important way to find out, are there going to be ischemic events in the brain, heart, or the lungs, especially in the arterial vessels. And this is a very important test, which is not in our armamentarium, but which help us to be more aggressive to prevent arterial event in certain areas. So I'm going to come to my second last slide where I'm going to discuss, is there in the unmet need, are we going to be able to harness this pathophysiology understanding better for therapeutics in the future? Now, I'm showing you here the B cell again. There is something called the B lymphocyte stimulating protein or stimulator protein. Without this protein, the B cells will not be active. So today, against the B cell, we have got rituximab. We've got a drug called belimumab, which acts against this B lyse. We've also got bortezomib, which can act on the plasma cells. You know that the B cells finally become plasma cells. So bortezomib can act on the plasma cells and eliminate the plasma cells from producing these antibodies. So all these three agents will prevent the B cells from forming the antibody. If the antibody does not form, it will not bind to the D1 domain of the beta-2 glycoprotein to cause endotheliopathy, which then gives rise to all the other events. Immunoglobulin can be used to mop off some of these antibodies due to anti-idiotype antibodies in the immunoglobulin. We spoke of complementopathy, and eculizumab acts against the complements, preventing inflammation from going up. There is a drug called defibrotide, which is an adenosine receptor agonist. It's a phosphodiesterase molecule or polymer, which actually is used by us in hepatic veno-occlusive disease, which occurs in transplant patients or those patients who have taken a new drug called inotuzumab. It is a antithrombotic, antifibrotic, anticoagulant, which causes fibrinolysis, which is defibrotide. And maybe its relevance will become more for patients who've got thrombosis. Statin HCQs could be added because they have got an added role of preventing inflammation and being antithrombotic. Cyclophosphamide, mycophenolate, and azathioprine are three immunosuppressive agents which can reduce our chance of antibodies binding to the beta-2 glycoprotein and also reduce the production of antibody from the B cells. In heparin, in the thrombosis of pregnancy, which Dr. Wagh is going to discuss, low molecular heparin and aspirin is the way to go, and I'm sure she's going to give us more data on that. And today we understand that the antibodies which are acting on the beta-2 glycoprotein are the D1 domain. So we've now got anti-beta-2-GP1 antibody against the domain 1 to prevent that D domain from being susceptible or sensitive to antibodies. So we'll be able to get a monoclonal antibody, which even if the antibodies are formed, anti-phospholipid antibody formed, they'll not be able to bind to the beta-2 glycoprotein. Hence, the endotheliopathy will not take place. And as Dr. Dasgupta said, APS is a heterogeneous condition. Its management should be tailored with a patient-centric approach based on the patient's individual risk assessment. So what is it? Is it a single risk? Is it dual marker, triple marker? Are there autoimmune diseases like SLE? So if there's an SLE with a single marker, it's just as bad as a triple. And what are the other traditional issues that the patient has, like comorbidities, like smoking, obesity, immobilization, malignancy, and other issues that can give rise to thrombosis? So each patient might be treated differently based upon that person's individual characteristics. I summarize by saying that LDA, low dose aspirin, is a good way to use in certain patients. Otherwise, it's going to be warfarin for those patients with thrombosis, irrespective whether it's venous or arterial. Keep it between 2 and 3, or 3 and 4 if it is recurrent, or add aspirin or a low molecular heparin to it. There is a role for complementopathy, and I'm hoping tomorrow in the future, there'll be more value to these antibodies against these complements. In pregnancy, LDA and LMWH has made a huge impact. More trial will be needed for future therapies and outcomes, especially in pregnancy. And I thank you for your attention.
Thank you, Dr. Bhave, for that amazing presentation. Moving on to our next speaker for today, our third speaker for today is Dr. Girija Wagh, a very highly popular and respected professor of obstetrics and gynecology at Bharathi Vidyapeeth Medical College and a senior consultant at Cloud9 and Apollo Hospitals, Pune. She has earned a fellowship from the Indian College of Obstetricians and Gynecologists, a fellowship of the International College of Surgeons, and a diploma in gynecological endoscopy. She was awarded the Anandibhai Joshi Award for Excellence in Medical Services, has been the Assistant Coordinator in the National Eclampsia Registry since 2008, Vice President of the Indian Chapter of Gestosis since 2014, and has had many other such prestigious posts throughout her career. She's also a national mentor for the Lakshya Labour Room Quality Improvement Initiative by the Ministry of Health and Family Welfare. Over to you, Dr. Giri.
Hello, good evening, and thank you for that very kind introduction. At the outset, I want to thank Dr. Amar Dasgupta for laying down the wonderful stage of the technicalities and the appropriateness behind testing for APLA. And of course, Dr. Abhay Bhave, I don't know whether he remembers, but we had shared a platform at the MOGS meeting once while we are discussing about anemia and pregnancy. And thank you for making it so very simple. And thanks a ton, Suburban, for bringing us this. Vineeth, you've been very, very kind and nice and a great host. So my commitment has been towards talking about obstetric APS, concerns and remedies. And it's indeed a privilege to speak among stalwarts such as Dr. Dasgupta and Dr. Bhave. So we all know that APS is an acquired, as he very clearly said, thrombophilia with clinical manifestations associated with presence of APL, and that is antibodies in patient's plasma. And obstetrical APS is a complex entity that may affect both the mother and the fetus throughout the entire pregnancy with high morbidity. The question which comes to my mind, and Dr. Bhave, I hope you answer at the end of the session, is does pregnancy act as one of those triggers prothrombotic conditions that predispose to venous thromboembolism, also referred to as acquired thrombophilia, as you rightly said, Dr. Bhave, a unique prothrombotic condition with heterogeneous symptoms from small ischemic episodes to something similar to CAPS is what is it signified by. And there are various laboratory criteria at this point in time, such as the LSE, the ACA, and the anti-beta-2 glycoprotein 1 antibodies. Then evidences of thrombosis on clinical examination. Even we gynecologists encounter them many a times. And of course, various kinds of pregnancy-related morbidities, such as unexplained miscarriages over 10 weeks of gestation, premature birth before 34 weeks of gestation, usually associated with preeclampsia or hypertensive disorder, and more than 3 or equal to 3 unexplained consecutive miscarriages. And this has become a new addition of less than 10 weeks of gestation, which also requires attention to identify whether this is APLA. History always paves the way to better understanding. And the link between RPL and a circulating anticoagulant was first reported by Nielsen, and that was LA. And as Dr. Bhave said, that LA many a times helps us in identifying conditions in RPL. Presence of an ACL was linked to miscarriages for the first time by Graham Hughes in 1984, and he named the syndrome. And RPL has been considered a hallmark of APS because we know that nearly about 28 to 30% of patients would have APL antibodies positive. So if you look at the key events that happened over a period of time, and I would like to mention only the key events that come on here are at around the age group of maybe from 1980 onwards, where I was doing my internship maybe in around 1990 when I was doing my residency. These were the times when these words were being spoken: anti-phospholipid syndrome, then the pathogenicity and everything else. And now we are here looking at various randomized trials where even the DOACs have been used, the direct oral anticoagulants have been used, and various consensus criteria have evolved over a period of time. And this picture I would like to reminisce from my own alma mater, that is BJ Medical College and Sassoon General Hospitals, Pune, in 1991, when I was a JR. And this was the time when I was left to my own self after this, because APLA was not very prolifically taught to me by my teachers, but I had to learn it myself. And I must thank Dr. Bhave for giving us very lucid understanding. So it is a first hit of something, and then something goes wrong, disarrayed, and then there is an activation of the second hit in the form of infection, trauma, surgery, inflammation is what we have understood. But what happens as a result is venous thromboembolism, arterial thrombosis, adverse obstetric events, recurrent miscarriages, accelerated atherosclerosis, increased risk of stroke, infarctions, and valvular heart disease. And all these things can happen in an expedited manner in pregnancy. So the presence of an APL associated with recurrent miscarriages in the first trimester, and more convincingly with fetal death or pregnancy morbidly in the second or third trimester, including symptoms related to placental dysfunction such as severe preeclampsia and or FGR, necessitating delivery of a premature infant before 34 weeks of gestation, and OAPS, that is obstetric APS, is referred to as the most frequent acquired risk factor for a treatable cause of RPL and represents an important health burden for women of childbearing age. And as we understood from Dr. Bhave, 50% of the times your low-dose aspirin would help these women. Now, the laboratory criteria for diagnosis of obstetric APS have evolved over a period of time. And here you can see on the screen the Sapporo criteria, which talked about screening, mixing, and confirmation tests. And if there are 2 or more occasions, at least 6 weeks apart, where LACs, ACL antibodies were positive. ACL antibodies, when detected by standardized beta-2-GP1 dependent ELISA, IgG and or IgM, medium or high titers, and even 2 or more occasions, at least 6 weeks apart. This time, they had not mentioned anything about anti-beta-2-GP1 antibodies. Over a period of time, so this was way back in 1999 and then evolved in 2003. Now, the Sydney criteria is something which has been proposed from 2006, wherein it talks about the LACs and the ACL antibodies with medium or high titer, more than 40 units IgG or IgM, and phospholipid antibody titers of more than 99 centile, 2 or more occasions at least 12 weeks apart, and anti-beta-2-GP1 antibodies, IgGN or IgM, titer more than the 99th percentile, 2 or more occasions at least 12 weeks apart. So these are some things which we are practically now taking into occurrence. We have understood from both our speakers that there are quite a few fallacies and problems associated in this. Now let's look at Mrs. PA, 34 years, a primary gravida, spontaneously conceived, came to confirmation at 6 weeks with no abnormalities or comorbidities. The 12 weeks uterine artery pulsatility index averaged to 2.9, which mandated me to start her on low-dose aspirin, 150 milligrams at bedtime. At 16 weeks, her pulsatility index was normal. The 19 weeks TIFA scan, the uterine artery PI was again normal. She missed the 23 weeks fetal 2D echo, which I usually recommend in all my patients who are beyond 34 years of around, a little older. And this was because of the COVID. And at 26 weeks, she came for antenatal care, physical antenatal care. And that time her blood pressure was 130/90, detected first time. And she had presented now with intrauterine death. After investigation, ANA and LA were positive, 14 days, and then after 12 weeks, and placenta showed thrombotic lesions on histopathological evidence. What must have gone wrong in PA? So it's possible that these antibodies are known to cause problems where there is binding to the decidual cells and extravillous trophoblast, giving rise to induction of inflammatory responses. Binding to trophoblasts, where there is inhibition of trophoblast proliferation and differentiation. So very early on in the pregnancy itself, it can affect. And therefore, the inclusion of early pregnancy losses less than 12 weeks also has been coming to being and causes induction of trophoblastic apoptosis, has anti-angiogenic effects, affects angiogenesis and spiral artery development, and therefore preeclampsia many times early onset ones, and activation of complement system, coagulation system interaction, fibrin deposition, and placental vessel thrombosis. And all these things, probably these factors must have come into being in her to kill her baby. So this looks like a very busy slide, but there have been evidences which have spoken about all these mechanisms, such as intraplacental thrombosis, inflammation, interference with annexin 5 functions, inhibition of syncytium trophoblast differentiation and defective placental apoptosis, and complement activation. And these mechanisms for APL-mediated fetal loss and complications have been well studied and proved in animal as well as in human studies. And heparin seems to be very, very important. And how does it seem to be important? It prevents the APL complications, not only by acting as an antithrombotic, but it is also known to inhibit the complicate cascades and modify the complement responses. And therefore, low molecular weight heparin seems to be useful in these situations. And recently, just in about 2021 this year, there has been an understanding about the autoimmune congenital heart block, which is a part of neonatal lupus syndrome and is a model of passively acquired autoimmunity disease caused by transplacental passage of circulating anti-ROSSA and anti-LASSB autoantibodies to fetal conduction and cardiac tissue. Heart immunohistochemistry from autopsies of fetuses died of CHB showed fibrosis, calcification, presence of macrophages, multinucleated giant cells in tissue of AV node, and fetal echocardiograms for PR interval measurement is the most useful low-invasive means for surveillance fetuses at risk of CHB. And therefore, all our mothers who have such kind of a history, it's always a good practice to subject them to a fetal 2D echo between 22 to 24 weeks of gestation. And the antenatal prediction of CHB is possible by evaluation much earlier on, is what the study showed, with serial fetal echoes beginning at 16 to 18 gestation week, since CHB developed usually occurs between 18 and 24 weeks of gestation. Immunoglobulin and dexamethasone have found to be useful in this particular study, which they have mentioned. So the international consensus criteria for diagnosis of obstetric anti-phospholipid syndrome looks at one or more unexplained dates of morphologically normal fetus at or beyond the 10th week of gestation, one or more preterm births of a morphologically normal neonate before the 34th week of gestation because of eclampsia or severe preeclampsia, recognized features of miscarriages before the 10th week of gestation with maternal anatomic or hormonal abnormalities and paternal and maternal chromosomal causes excluded, and laboratory criteria where LA is present in the plasma on 2 or more occasions, ACL of immunoglobulin G or IgM isotype in serum or plasma present in medium or high titers, and anti-beta-2-GP1 or IgG or IgM isotype in serum or plasma present on 2 or more occasions at least 12 weeks apart. So these are the various factors which can help you in identifying your patients, and thrombotic events, gestational morbidity are the ones which act as triggers to perform these tests. We had Mrs. SB, SLE APH patient who had recurrent pregnancy loss, was diagnosed as SLE. She had undergone a hysteroscopy once for incomplete evacuation of uterus in a previous miscarriage, had to undergo a GNE, And right now, at this point in time with me, her USG showed mesenchymal placenta, and she had to be taken for elective C-section delivery at 34 weeks for reverse end-diastolic flow and fetal growth restriction. And I remember I delivered this baby of 1 kg that time. So this was her very, very poor obstetric history, as you can see, before she presented to us in the present pregnancy at 8 weeks with a natural conception. She was under treatment for SLE with HCQS 300 milligrams daily and was now in remission. She had herself stopped taking these medications recently during the first trimester. And according to her, the SLE was triggered due to ultraviolet therapy that she had taken, vitiligo, which she suffered from. And this was a scan you can see at 7 weeks or 5 days. Adenomyotic abnormal subchorionic lacunae was our query, or where we also probably thought that it may be a chorangioma or a partial mole, which was ruled out. And then we have to remember that, as Dr. Bhave said, that SLE can be exceptionally heterogeneous clinical spectrum, with mild disease limited to skin and joints, to renal disorders, to CNS affliction, severe cytopenias, and thromboembolic events. And it is a clinical challenge because there can be prediction of disease flares and identifications in individuals that are likely to evolve. Severe disease is very difficult. And there are quite a few good biomarkers who can help us in determining this and to help women not get affected or, and get some multisystemic disorders. And if you look at the hallmarks considered to drive the disease in a vicious circle are the autoantibodies such as ANA, APLA, interferon alpha, and these contribute to formation of immune complexes with nuclear antigens, causing the vicious cycle of antigen exposure, autoantibody production, inflammation, and organ damage to set in. And therefore, we have to be on guard. And in Shobha, who I showed you just now, on table, it was a surprise. She had an extremely thinned out placenta. And this, when we had to do a swift obstetric hysterectomy because she started bleeding, and the histopathology showed that it was actually a placental acrete syndrome. So inflammation, autoimmune abnormality, association of APLA, everything comes together and makes these patients quite special. So obstetric challenges do not stop only with delivery. Thrombogenic initiation starts as early as 6 weeks, and we have to be aware of that. Obesity and sedentary lifestyle seem to be adding upon. Preeclampsia, FGR, intrauterine, fetal death, stroke, DVT, pulmonary embolism, abruption, acute kidney injury, HUS, TTP, death, all seem to be accumulated in these patients. And even after delivery, they become our responsibility to look after them and to take care of them. And these are the various antiphospholipid antibodies that we've been talking about for quite some time. But what is very important is they don't only cause damage to the trophoblastic tissue, but it has been identified today that even the endometrial cells and the decidual cells seem to be affected by these abnormal actions which ensue in the woman's body, giving rise to infertility. And there are evidences to each one of these factors that I'm saying. Increased risk of DVT and preeclampsia due to hormonal stimulation and implantation failures. And therefore, if we are going to embark on assisted reproduction, it's important that you screen these women for these conditions before you decide to take them on this surgery, because on this particular intervention. Then mothers during pregnancy are at risk, and be on guard to all those mothers who are showing you thrombocytopenia, preeclampsia, eclampsia, and abruption are commonly associated. Early miscarriages, stillbirths, prematurity, FGR. And what happens to the infants? Infants also have an increased risk of neuropsychological disorders. So it's an entire spectrum that we as ObGyn specialists are in the center, and we have to be aware of this and try to modify this as much as possible. So whenever we look at the clinical categorization and approach, let's say you have a patient who is APL positive woman, would you go give her a primary prophylaxis for thrombosis? It's not recommended unless and until she has other cardiovascular risk factors, SLE, or is a high-risk APLA. And then in that case, you may consider giving her low-dose aspirin or LMWH. Antepartum, there would be no treatment necessary for her. And if it's a low-dose aspirin, there can be, especially in those whom you have assessed to have a risk of preeclampsia. And if it's a high risk, you may consider combination of both. Postpartum, always remember to give them thromboprophylaxis, at least low-dose aspirin for 6 weeks, and immediate 14 days, you may consider giving them low molecular weight heparin. If she is an obstetric APS, then primary prophylaxis for thrombosis generally is not recommended again. Antepartum, the same policy would continue, but if she has had FGR or uterine pulsatility index is abnormal, or she doesn't have an IUFD, then you can just consider giving her LDA. But if she has any of these, then you may consider giving her LMWH after confirmation of the fetal cardiac activity at 6 weeks of gestation. And do not forget any of these women postpartum. Now, you have a woman who has approved vascular APS before she becomes pregnant, and we heard Dr. Bhave telling us that you would give her warfarin to the target of INR of 2.0 to 3, and LDA plus therapeutic dose of LMWH would continue in a confirmed pregnancy with frequent surveillance. Switch to heparin from warfarin much early, and periconceptually is always better. And postpartum, restart warfarin 4 to 6 after vaginal delivery and 6 to 12 hours after C-section. Now, there is one more entity which has been coming up, and that is the non-criteria obstetric APS, where most identified causes of RPL and its accurate diagnosis is a requirement for optimal treatment. Some patients do not fulfill the revised Sapporo classification criteria and the original APS classification criteria, and these would be called as non-criteria OPS. Controversy about their inclusion within the spectrum of APS and eventually the treatment as having OBS APS continues. And it's a subset of patients may also have clinical characteristics, and none of these antibodies would be consistently positive. And these patients are recognized as seronegative APS. And you can see a typical story here where the woman has undergone adverse outcomes all the time, has had a flare of SLE once in a while, and then she has had a baby which was finally delivered in her 5th pregnancy with a lot of support systems, but she never showed any of these antibodies positive. So to improve is to change, and to be perfect is to change often. And therefore, we have to be looking at the overview of APL carriers, management of cardiovascular risk factors, consider LDA in high-risk patients in the triple positive test once, secondary prevention of VTE is to be undertaken, and secondary prevention in arterial thrombosis also we have to look into. And usually gynecologists have an opportunity of looking at these women during pregnancy, which is identified to be the most stressful condition. And prevention of pregnancy complications, as we have been speaking about, has to be taken. I already showed you, and this comes from the EULA 2019 guidelines, which talks about giving a combination of LDN, LMWH, and so on. So we all know that this anti-phospholipid antibodies act at cellular levels, giving rise to thrombosis, pregnancy loss, preterm delivery, particularly in patients with preeclampsia. And procoagulation state is induced, which is mediated by thromboxane A2, giving rise to inflammation, complement activation, and thrombosis. And reduction of this thrombogenic state could explain the benefits associated with LDA used in these patients. And LDA, either alone or in combination with heparin, prevents recurrent pregnancy losses in patients with APLA. And LDA plus unfractionated heparin is associated with better outcomes than aspirin alone in those high-risk or moderate risk women. And then there are various other promising agents which have been come into being, and it's always a good practice to consult an expert hematologist like of Dr. Bhave. We have quite a few in our city of Pune, whom we always take them as a part of our team to use these different anticoagulant, antiplatelet, and immunomodulatory drugs, and hopefully they would bring us a better respite and better results. The ACOG looks at various risk factors to start low-dose aspirin, and autoimmune disease, systemic lupus erythematosus, and APLA happens to be one of the high-risk factors in these factors. Likewise, the Gestosis India Association has been speaking about the Gestosis score, which you can just do a clinical history-based score, which you can conduct on the patient at 12 weeks of gestation or in the first trimester. And any woman who has a history of autoimmune disease or any patient who is going to be considered for ART, they would be scored as 3, which is taken as a high risk, and they can be considered for using LDA, closer surveillance, or even sometimes LMWH. So initiation of low-dose aspirin for prevention can be considered at least by 12 weeks of gestation, or maybe at least by 16 weeks of gestation, because placental window is open from 8 weeks to 16 weeks of gestation. Early therapy may be important since the pathophysiological features of thrombosis develop early in pregnancy, weeks before clinical disease is apparent, and available evidence is inconsistent about the importance of early initiation of therapy, possibly because aspirin has major effects on prostacyclin production and endothelial function throughout gestation. And if aspirin is not initiated at the end of first trimester, initiation after 16 weeks, but before symptoms develop, by 26 weeks of gestation have been shown to be effective. When do you discontinue? No consensus. Continue low-dose aspirin until delivery. Some advocate discontinuation at 36 weeks of gestation or 5 to 10 days before expected delivery to diminish the risk of bleeding during delivery. But there have been no adverse maternal or fetal effects related to use of LDA at delivery have been proven. But if you are giving patient LMWH, then it's always better to stop it at 36 weeks of gestation or at least about 6 hours before the patient is getting in for an operative delivery or an active delivery. And there are few consensuses now available about aspirin, and that is highly effective in preventing preterm preeclampsia. It's given at 150 milligrams at night, initiated between 11 to 14 weeks or at least by 16 weeks. Prescribed to a high-risk population, daily aspirin 150 milligrams from 11 to 14 to 36 weeks to high-risk women, reduces the length of stay in the neonatal intensive care unit by 68%, has no evident beneficial effect in women with chronic hypertension, and beneficial effect on preeclampsia rates depends on adherence to treatment. Very, very important, because sometimes patients may not adhere to the treatment, and that is the biggest fallacy, and more studies are essential to identify this. Maternal weight can influence the effective dose, and therefore, whenever you are looking at the dose administration, if the patient is more than 90 kg, consider giving her 200 milligrams instead of 150 milligrams, while between 40 to 90, 150 milligrams would be appropriate. And if you have a woman who is 40 kg or less, then 100 milligrams could be appropriate. So there are various differences between the clinical complications, and there is no clear subclassification. A patient with a diagnosis of APS prior to pregnancy should not be classified as OAPS, and the pathogenesis of manifestations associated with APLA includes not only pro-coagulation disorders, but also pro-inflammatory disorders. And there is considerable variability among the clinical manifestations associated with APLA in different patients. And there are growing number of cases that can be clinically classified as OAPS carriers. However, the presence of classical APLA defined as a seronegative OAPS cannot be demonstrated. And so as complex the disease, so will be the complex it is associated with it. And of course, there are two arenas which we have to consider. One is pregnancy calling as it as a trigger? And secondly, whether there is any way of determining the patient's susceptibility to throw a very severe disorder as she goes by. Maybe some sort of genetic microarrays would be probably the next thing which we'll be able to identify. So with this, I end my talk. Wish you all a Merry Christmas and a Happy New Year. And thank you for giving me this patient hearing and opportunity.
Thank you for that very crisp and dynamic presentation, Dr. Girija Wagh. Because we are short of time, let me just run past this very quickly to all the audience. If you look to the chat box, you'll notice a link has been posted. Please click this link and enter your details exactly how you want it on the certificate. As I mentioned again, the link is on top of the chat box. Please click the link and enter your details how you want the certificate. Now, for our Q&A session, because of restrictions of time, we will have to restrict the number of questions we are answering today. The rest of the questions you may mail us, and we will reply you with a response. So, my first question to Dr. Abhay Bhave, there is a very practical query asked by a physician here. If a patient comes positive for lupus anticoagulant, and the patient is told to repeat after 12 weeks, one, the patient may never return. And even if the patient does return, what kind of treatment or what is our protocol to follow until the second test is done? Dr. Bhave, you are muted currently. Please unmute yourself.
So you're telling me that the patient had a thrombus, that's why a lupus anticoagulant was done?
Yes.
And the LA is positive in a patient with a venous thrombosis or arterial thrombosis, whatever it is. So in this case, if the patient is positive for a lupus anticoagulant, I consider it as high risk. So I would initiate this patient on warfarin. I'm not going to wait to start treatment for 12 weeks to know whether it was a transient lupus or not. We'll start therapy with warfarin. We'll not choose the DOAC. In the meantime, we can ask for the beta-2 glycoprotein and the ACE antibodies. But if the LA is strongly positive or is significantly positive, this patient goes on warfarin.
Thank you, doctor.
We'll take the treatment irrespective what the other two antibodies are going to come, because we all know LA is the one which is very prothrombotic.
Thank you, Dr. Bhave. To Dr. Girija, there's a question. As Dr. Bhave mentioned in his presentation, that thrombocytopenia is a very common symptom of this. Should pregnant women showing even mild thrombocytopenia be worked up for APS?
See, actually, thrombocytopenia of pregnancy is another very, very difficult, sort of an analysis to make, because there's something called as gestational thrombocytopenia, which usually would not be very severe. It will be between 80,000 to a lakh of counts, and would not cause any harm whatsoever and would be occurring in the later part. You can just do it based on history of the patient. However, we also have to remember that the northeastern community in our country also has thrombocytopenia, but they also have a very high incidence of APLA syndrome. I hope Dr. Bhave would agree to this. So we wouldn't immediately ask all patients of thrombocytopenia, but there is significant thrombocytopenia which is showing counts of 70,000 or less and is persistent, because 80,000 till 80,000 you would accept it as gestational thrombocytopenia. Or if she has any strong history, it's always a good practice to ask about family history also. In that situation, you would be justified in at least doing the lupus.
Thank you, doctor. To Dr. Amar Dasgupta, sir, there's a question. In solid phase testing, is it necessary to do cardiolipin and beta-2 glycoprotein IgEm with the IgG, or is only IgG enough?
No, so I think both are required. It is either or. So if you have positivity with one of the two, I think that is significant. So both should be asked.
Okay, thank you, Dr. Amar Dasgupta. As I mentioned, because of lack of time, we are not able to answer everybody's questions. Please, you will be receiving emails from our side with a recording of this presentation. You can please share that with your colleagues who may have missed today's sessions. And any questions you ask can be sent to us. We will try and reply with the answers to those questions. Let me finally thank the speakers for sharing their knowledge and their very valuable time with us today. And thank you everyone who attended today. Have a great day and stay safe and have a good evening.
Thank you, Vineeth. Well done. All the best and Happy New Year, everybody.
Happy New Year. Happy New Year and the holiday wishes to everyone.